Welcome to all of you who have joined us today on today's topic titled Canada's Medical Assistance in Dying, What You Need to Know. I'm Martin Frith on the board of Humanist Canada and your host today. So let me take a moment just to go over a few housekeeping items with you. You should be listening in listen-only mode. However, there will be an opportunity to ask questions through the Q&A which is at the bottom of your screen. I suggest you take a moment, if you haven't already, to adjust your audio settings. And today's webinar will be 60 minutes in length, with time allotted at the end for questions and answers. And if you have some along the way, certainly feel free to put them into the question bar. They will come up and we'll see them. And if we have a moment, and it seems an opportune moment, we'll be able to present them to our speaker. So, before I introduce our speaker, let me take a moment to set some context. In June of 2016, the Parliament of Canada passed federal legislation known as Bill C-14, allowing eligible Canadian adults to request medical assistance in dying. Since MAID was legalized, more than 6,700 Canadians have chosen to die peacefully with the help of a physician or a nurse practitioner. On September the 11th, 2019, the Superior Court of Quebec found that it was unconstitutional to limit access to MAID to people nearing the end of life. The ruling arose from a constitutional challenge filed by Jean Truchon and Nicole Gladue, two Quebecers with incurable degenerative illnesses. Mr. Truchon and Ms. Gladue met all the requirements of the federal and Quebec laws, except their deaths were not imminent. Denying them access to assisted dying because they're not terminally ill, in the words of Justice Beaudoin, forcing them to endure harsh physical and psychological suffering, which she stated in her 197-page judgment. The court then declared that the reasonable and foreseeability of natural death, the criterion in the Federal Criminal Code, as well as the end-of-life criterion in Quebec's provincial law on medical assistance in dying, it was unconstitutional. Justice Beaudoin suspended her ruling for 6 months to allow legislators to deal with its fallout, but exempted the two plaintiffs, Mr. Truchon and Ms. Gladue, allowing them to proceed with their bids for medical assistance in dying. The court's ruling was to come into effect on March 11, 2020, unless the federal government requested an extension. So our speaker today will be providing insight into the current legislation, the status of accessing medical assistance in dying across Canada, and what it means for all of us for a peaceful death. So our presenter today is Shanaaz Gokool. She's a lifelong human rights activist who has led numerous grassroots initiatives in the Greater Toronto Area. She's held leadership roles in the private sector and nonprofit organizations, including Amnesty International, Innocence Canada, which was formerly the Association in the Defense of the Wrongly Convicted, and leadnow.ca. As the former CEO of Dying with Dignity Canada, she transformed the organization into a leading national human rights charity defending Canadians' end-of-life rights. She was a go-to authority on medical assistance in dying. She has tested before parliamentary committees at the federal and provincial levels, and she's created a unique human rights framework for legal and public advocacy for medical assistance in dying, which has been recognized both nationally and internationally to the audience she has spoken to. So Shanaaz, thank you for making the time to talk with us today about this incredibly important human rights issue. So if you could imagine lots of applause happening.
Wonderful. Thank you so much for that kind introduction, Martin, and special thanks to Humanist Canada for inviting me to speak today. Can you hear me okay? Yeah? Just, Martin, can you hear me?
I can hear you very
Okay, wonderful,
clearly.
wonderful. Just want to make sure. And thanks to all of you who are tuned in this afternoon as we all practice our exercises in social distancing. Webinar is a great opportunity to step back in the privacy of your own space, and hopefully we can all go through this presentation together, maybe learn a few things, and probably realize that there's a lot more questions we have to ask to understand where we are, today in terms of assistance in dying in Canada. So I'm just going to just trying to take the controls, Martin, but
okay, if you send a request.
Let's do that again. Yeah, okay, there we go.
Okay.
And so today I'm going to be largely speaking about what's happening at the federal, the national level. There are a lot of access issues going on at the provincial level, but that would require at least another hour and a half. So today we'll look at really what is happening in terms of eligibility and the safeguards. So I'm going to start with a super brief history. We're going to take a look at what's in the current legislation in Bill C-14, some of the issues and some of the people who are excluded from Bill C-14. We will look at some key cases that help us to understand or help to inform what we think certain things mean that still need to be clarified. And then we're going to take a look at some of the eligibility requirements and some of the safeguards in the draft federal legislation Bill C-7. And some questions, and then some possible calls for action to sort of understand where we are. I'm going to, throughout this presentation, speak primarily at a very high sort of overview level because of time and because, I think for the average person, there are certain key questions that, we need to understand so that we can have the conversations we need with our family and friends. There's certain questions to help inform some of the advocacy that Humanist Canada, but other national organizations might want to consider as we go through the coming weeks when Bill C-7 goes through all the parliamentary processes. So there are going to be a number of things. What that means is there's going to be a number of things that I'm going to leave out, but certainly feel free to ask them when we get to the question and answer period. So my next slide on the brief history, super brief, just to take us all back to sort of the modern around assisted dying, which really starts in 93 with Sue Rodriguez's challenge that went to the Supreme Court. As most of you will know, Sue Rodriguez was a BC woman with ALS and went to court to be able to access physician aid in dying. It was a split decision against her, a 5-4 decision. And so she wasn't able to access it legally, though there is much talk. People do know that she was able to access an assisted death, though who assisted her remains, as it should, I believe, today, a mystery. But she really sort of focused the issue and asked that very famous question that we still continue to ask today around assisted dying and some of the people who are excluded: who owns my body? Whose body is this? Who owns it? Who can make decisions about it? So we fast forward to 2015. On February 6, 2015, the Supreme Court of Canada's decision, landmark, groundbreaking human rights decision, Carter v. Canada, came out. And that was led primarily by 3 women: Gloria Taylor, who had ALS, also from BC; Kay Carter, who had severe spinal stenosis, also from BC; and Elaine Chapre, another BC woman who had progressive multiple sclerosis. and both Kay Carter and Gloria Taylor had died before February the 6th, 2015, and the case was largely carried forward by Kay Carter's daughter, Lee. And so that decision, which allowed assisted dying, came into effect. The decision was suspended for 1 year to give governments time to legislate if they so choose. And that resulted in Bill C-14, as Martin just mentioned, which received royal assent in June of 2016. Then in 2019, as Martin just mentioned, in September, there were two main challenges to one of the eligibility criteria, that your natural death has to be reasonably foreseeable. One was in Quebec. Jean Truchon had cerebral palsy, and Nicole Gladue has, they both still have, as far as I understand, I don't think they've accessed assisted dying yet, or at least it hasn't been reported. She has post-polio syndrome, and they've both had significant disabilities as a result of their conditions since they were children. And that was the case that sort of led to the striking down of natural death has to be reasonably foreseeable, and the terminal provision in Quebec's legislation. It also, that decision caused another case in BC, Julia Lamb versus Canada. That case was launched right after the federal legislation in June of 2016. She has severe spinal atrophy, muscular atrophy, and was also challenging some of the same provisions. That case was suspended and abandoned because one of the government's own experts testified that if Julia Lamb decided to refuse personal care, medical care, that her natural death would be reasonably foreseeable. And that has resulted in the draft legislation that came down at the end of February, Bill C-7. So that's high level, very, very brief. So many more details to sort of go through there, but I think that gives us a good sense of where we are. And I just want to review some of the provisions in Bill C-14 to remind us of where we are. I'm not going to go through all of these in great detail, but here is the definition of grievous and irremediable. So in order to be eligible for an assisted death under Bill C-14, you have to have a grievous and irremediable medical condition, and it means all of these four things: that the person's illness, disease or disability is serious, it's not curable by any means that's acceptable to the person. People cannot be forced to accept treatments that they don't want. You must be in an advanced state of irreversible decline in capability. The person must have physical or psychological suffering that's intolerable to them and can't be relieved by any means that they find acceptable. And then the big one that's bolded: their natural death has become reasonably foreseeable. We're going to come back to that in just a moment. But let's just take a look at some of the safeguards that are also in Bill C-14. So when you make a written request for medical assistance in dying, it has to be signed by 2 independent witnesses. And the parameters around who's independent seem fairly strident. Can't be someone who is providing you personal or medical care. Can't be someone who's known to be a beneficiary in your death. And that's really caused quite a burden on a number of people. And many of you will know that Dying with Dignity Canada set up a national independent witness program in 2016. And when I left in July of 2019, the organization was probably witnessing, and I would say between 15 to 22% of all assisted dying deaths across the country. It's a significant number. The mandatory 10-day waiting period from the time you make the request to the time you can receive assisted dying, which can be waived should your death or your loss of capacity be imminent. And then this is a very important one. Immediately before receiving medical assistance in dying, the person has to have capacity to be able to say they still want it, or to be able to withdraw if that's the case. And that has also caused some issues. And so just going to the next slide. So let's look at some of the issues. I think by now everybody has heard some of the problems around natural death being reasonably foreseeable, because the legislation initially meant, either there was some proximity to death, and for many people back in 2016 and the early part of 2017, for clinicians who have to make that decision if the person's natural death is reasonably foreseeable, it meant imminently dying, terminally ill. And clinicians across the country were using different interpretations of what that actually means. And in some ways, it is a bit nonsensical, because for about 93, 95% of us, our natural deaths are reasonably foreseeable. And the second problem is the late stage consent requirement. So for people who have already been assessed, they've been found to be eligible. If something should happen, if their health is so precarious that they slip into a coma, they have a stroke, they lose capacity because of the medications they're taking to control their pain and their symptoms, they're unable to have an assisted death. And as I've just mentioned, the two independent volunteer witnesses is a problem. Then there are exclusions that are not addressed in C14, and they're still not addressed in Bill C7, but we'll talk a little bit about what we might be able to do in the coming weeks to take a look at these things. So advanced requests for MAID. There's one major category. So people who would like to be able to make an advance request for a time somewhere fairly far down in the future. So should they have dementia or some other neurological degenerative condition where at the time of their dying, which could be protracted, especially with something like dementia or Alzheimer's, that they would be able to have an assisted death. Then there's that subcategory I just referenced around the late stage consent requirement, people who have been assessed and approved, but lose capacity in the days, hours before they're supposed to be able to receive an assisted death. They are currently excluded if they lose capacity. People with mental illness as the sole underlying condition are largely excluded, but not totally excluded under C14, because people who have anorexia or bulimia, their physical articulation could take them to the brink where their natural death is reasonably foreseeable. But for others who might have severe, chronic, intractable mental illness, such as depression, they are completely excluded if it's the sole underlying condition. Certainly, there are people who've had medical assistance in dying who have had issues with mental illness, still had capacity, and had other underlying physical conditions which help them meet the eligibility criteria that we just discussed. And people who are under the age of 18, mature minors who can already make their own life-ending medical decisions, such as refusing and stopping treatment, they are also excluded from the legislation. And so these three at the bottom, these three categories of people, it was required in Bill C14 that Parliament enact studies, reviews to sort of examine these issues as it relates to medical assistance in dying. However, Bill C14 did not ask and require that those studies would include recommendations for legislation. And there was a 5-year clause that these studies would be reviewed after June 17th, 2020. And so we know with this government, their intention is to have further consultation and discussion around advanced requests for MAID for people with dementia, mental illness is a sole underlying condition, and mature minors. But there is nothing that requires the government in C14 to enact legislation to include these groups of people. So you could see that there are definitely issues and that there are problems with C14. And there's also some questions that need to be answered about some of the draft language in the legislation. So this takes us to our next slide. two key stories, cases that developed in the interim, so one in 2017 and one in 2018, which really help us to understand the current legislation in Bill C-14. So in 2017, and I'll speak about both of these women. The first is A.B. and the second is Audrey Parker, who was very public in the fall of 2018. I knew both of these women. One was in Ontario and one was in Nova Scotia, and they were plain spoken, down to earth, determined women who had a lot of conviction in their individual fights. So with A.B., she was 77 years old and had a severe case of, and rare case of osteoarthritis. She was on long-term disability when she turned 53. And over the course of the next 20 years, her condition degenerated significantly. And in her early 70s, she had to go into a long-term care home to be able to receive the care that she needed, that she couldn't provide for herself. So I met her in April of 2017, and by the time I met her, she had made 3 requests for medical assistance in dying. There were 3 dates that were set. Yep, this is the date you're going to have an assisted death. And each time, days before the scheduled date, the clinician canceled. They were very worried that her condition was more chronic, she wasn't imminently dying, and the penalties for clinicians who fall outside of the law are significant. There are many, many years in prison, and I believe it's 16 years. So clinicians were very hesitant, and sort of understandably so. So A.B. went to court in Ontario, and I was in court with her lawyer, and that's him in the picture there. That's Andrew Faith, a lawyer here in Toronto, and my former communications officer, Corey Roof. We said we would be there to support her. And it was really interesting, the decision that Justice Perel released in June of that year, where basically he said that maybe this should have really been a charter challenge, and nobody was being helpful here. The federal government wasn't very helpful with their language of natural death has to be reasonably foreseeable. Canada hasn't been very helpful in sort of what that means. Ontario government hasn't been very helpful, but he was gonna help everybody out, recognizing that it was still very early days. It was not quite a year since assisted dying was legalized in the country, and that clinicians could use some assistance in understanding what reasonably foreseeable means as it relates to medical assistance in dying. And so what he said was, one, that A.B.'s case was heartbreaking. She spent most of her days in this long-term care home in a chair. It was an automatic recliner that she would adjust, trying to find a position where she wasn't in a lot of significant pain. And if I didn't meet her and have multiple conversations with her, it might be hard for me to understand, but she would be constantly adjusting this chair, and then you'd hear these sharp intakes of breath because she just couldn't find a spot that was comfortable. She couldn't sit up, she couldn't eat with other people, and she rarely left her room. And he said, so her case was heartbreaking, and that for clinicians, understanding what natural death, becoming reasonably foreseeable means, is what also it doesn't mean. So you don't have to, the person doesn't have to be terminally ill. That so long as the person was on the trajectory towards death, they weren't coming back. A.B. was not going to come back from the condition that she was in. That is enough to help clinicians determine that yes, that person's natural death is reasonably foreseeable, and that clinicians need not opine about the length of time a person has left to live in their natural lives. And so declared that yes, A.B. Her natural death was reasonably foreseeable. She's the only person that whose natural death was declared reasonably foreseeable in a court. And that case helped clinicians and lawyers and college regulators for doctors and for nurse practitioners all across the country understand that instead of looking at reasonably foreseeable as a terminal illness with maybe 6 months or a year, if you look at AB, she was 77 years old. Some clinicians used these frailty charts, which sort of you plug in the person's age and their medical conditions. It gives you sort of a life expectancy. And so AB's life expectancy for some clinicians was 10 years. And that became a standard, not for all clinicians. It wasn't consistent. It is not consistent across the country, but for a core group of clinicians who assess and provide medical assistance in dying, they look to the AB decision. And the AB decision was instrumental and critical. Her case helped, I would say, thousands more be able to access an assisted death from June 2017 to now. So I just want you to remember, what the judge said, that reasonably foreseeable, yes, it means proximity to death, and it also means that a person is on a predictable trajectory towards death, as AB was. And in her case, her lifespan was at least 10 years. She was a very robust woman. She had assisted death in August of 2017. So that was very helpful in that clarification. Audrey Parker, in the fall of 2018, started speaking very publicly about the cruel choice that she was facing. She's a woman from Halifax. She had breast cancer that had metastasized and had spread throughout her bones and into her brain. And so she had picked November 1st, 2018 to have an assisted death because she was very worried about losing capacity. But Audrey just wanted to live for one more Christmas. And so in my first conversation with Audrey, the beginning of October in 2018, we were chatting on the phone and she kept referring to herself and her circumstances as, people in my category. People in my category, this is so unfair for people in my category. And I was listening to her on the phone and I'm like, what is her category? What is she talking about? Because as I mentioned earlier, we thought of people like her who have been assessed, who were approved, who are eligible as part of the advance requests. But sometimes you need someone in front of you to help you see what was there all along. And then I had this sort of aha moment. And I said, oh, well, your category is assessed and approved. And she's like, that's exactly right. And I said, and you've crossed all the T's and you've dotted the I's, and you're not going to change your mind. You should be able to have an assisted death, even if you lose capacity. You just want one more Christmas. Well, that's exactly right. And so Audrey Parker really helped the country. And there was just an outpouring of compassion for her. To understand that for people who are in her situation, she should be able to go ahead and sign a waiver that says, look, even if I lose capacity on January 2nd, I'd still want to go ahead and have an assisted death. Unfortunately, while that was not the case for Audrey Parker, Dying with Dignity and others really campaigned around her subcategory of people who are assessed and approved, and that they should be able to make a waiver and waive the late stage consent requirement for medical assistance in dying. I say, unfortunately, she wasn't able to do that for herself, but Audrey Parker had a beautiful death from sort of all accounts. And I was at her celebration of life in Halifax a week after she died, and her ashes were in a Chanel bag. This woman had lived her life larger than life in so many ways, and became an activist in the final weeks, 8 to 12 weeks before she died, on this issue, and touched so many lives. in Halifax, and then of course across the country. So these two particular stories of these two women are so essential for what's going to come next in Bill C7, which I'm just going to show you, see if that'll, oops, I'm trying to get, this slide is actually from the Government of Canada. I'm sure that if you want to see the slides, Martin and others can make them available for you. But since the legislation is enacted, it's actually now over 13,000 MAID deaths in the country. So just to give you a sense, there's just some statistical information to give you a sense of where we are, and we have seen a gradual increase, and keeping in mind that some of that, a good chunk of that increase comes from AB and what natural death being reasonably foreseeable means. And it's important to remember that because that case was not appealed by the federal government. It stands. It is the legal precedent for helping us understand what reasonably foreseeable means. So let's talk now about Bill C7. And I'm not going to go through everything. I'm just going to pick out some of the pieces that I think will be of most interest to most people who are, trying to understand what it means for, family and friends, and for them, and for ourselves in the future. So the first thing we're going to look at is the eligibility criteria. You will see that natural death being reasonably foreseeable has been struck as an eligibility criteria. Great, good news. But then you will also see, for the purposes of medical assistance in dying and eligibility, a mental illness is not a serious, incurable illness, disease, or disability, which is not factually true, and of course now creates no avenues for people with severe mental illness as the sole underlying condition to be able to access assisted dying. It's hugely discriminatory. It stigmatizes, internalizes issues of real illness for people that suffer with severe mental illness. So that is a big problem. Then we're going to take a look now at the safeguard system. And I'm going to try to do this in a way where you don't end up terribly confused, but it is a little bit confusing. So what the federal government has done is they've struck natural death being reasonably foreseeable as an eligibility criteria, and they have now still though used reasonably foreseeable, natural death reasonably foreseeable, to determine which safeguard system you're going to be on. So with Bill C14, there was one system. If you were eligible, then these were they're very clear safeguards, and they apply to everyone. What they've done now is they've created a two-track safeguard system. And so one is if your natural death is reasonably foreseeable, and the second one on your right is when natural death is not reasonably foreseeable. They just couldn't abandon that language, as problematic and complex as it has been proven to be throughout the country. And so on the first side, I'm going to flip through these slides back and forth a little bit. You only require now, in terms of safeguards, one independent witness as opposed to two, and that can be a paid personal or healthcare worker, not the people who are assessing and providing assisted dying, but anybody else that's providing personal or healthcare. That's great. It really loosens the parameters and will make it much, much easier for people to be able to proceed with their request for an assisted death. They've also removed the 10-day reflection period if your natural death is reasonably foreseeable. And I'm just going to go ahead to this next slide. Oops. Here we go. There we go. And it also allows, if your natural death is reasonably foreseeable, to be able to make an advance consent. So what we were calling back in 2017 and 2018, Audrey's Amendment in honor of Audrey Parker. And so if you've written in, if you have entered into a written agreement with your clinician that says, look, we've set the date. You have to set the date. That's very important in order to be able to make the advance consent. So in Audrey's case, if she had said, yeah, I want to have assisted dying on January the 2nd, then the person come January the 2nd, if she lost capacity, she would still be able to have an assisted death. Or if she lost capacity on December 20th, she would be able to have it at that time as well, as long as it's clearly written in her request. So that's great news for if your natural death is reasonably foreseeable. It's a little bit more problematic as we turn to the right side of our screen if your natural death is not reasonably foreseeable. So the witness requirements are the same, but then there's other things that are introduced. And of the two independent clinicians who are assessing if you are eligible for medical assistance in dying and your natural death is not reasonably foreseeable, one of the assessing clinicians must have an expertise in the person's medical condition that's causing the suffering. What does that mean? It's a very good question. We'll come back to it. Then there is a minimum of a 90-day waiting period that can be waived if capacity loss is imminent, provided that both assessments have been completed. Now, you have to have a grievous and irremediable medical condition that causes you intolerable suffering. So there is something, I think, for a lot of people that's really problematic. If you have intolerable suffering and you are eligible, they're saying on this particular track, you still have to wait 90 days before you can have an assisted death. So that is problematic. And then if we go back to our second slide, which, oops, come on, here we go. There are other things that have been added. And some of them, making sure that people, know of all the options in terms of health supports that are available to them. This one here, the practitioners agree with the person that they have discussed and appropriately considered reasonable means of alleviating their suffering, and agree with the person that serious consideration was given in their MAID decision. That is potentially problematic as well, that they have to agree with their person that the person has given serious consideration. And I don't think you see it on the slide, and I apologize for that. But the ability to access Audrey's Amendment is denied. So if you are on the second safeguard system where your natural death is not reasonably foreseeable, you are not able to have an advance consent should you lose capacity. You are able in these two systems to be able to move from your natural death not being reasonably foreseeable to your natural death has become reasonably foreseeable. I'm not sure what that mechanism is going to look like for clinicians. I think there's a lot of questions around it. And then I think there are questions of if you've moved from one track to the next track, are you able then at that point to have an advance consent should you lose capacity? So you've seen my slide here. Are we confused yet? And what kinds of problems and issues are going to arise with some of the problematic language that's currently in Bill C7? So I think there's some really important questions that we want to ask. What does reasonably foreseeable mean? The Justice Minister at the time of unveiling the legislation seemed to say that it meant for people who were dying. And then a few weeks ago, Joan Bryden from the Canadian Press interviewed Professor Jocelyn Downey and Dr. Stephanie Green from the Canadian Association of MAID Assessors and Providers. And both of them expressed some concern because we know that there's a legal precedent for reasonably foreseeable, and it's based on the AB decision. And that would mean that people who already can access an assisted death under C14, people who have Parkinson's, who have Huntington's, in some cases who have dementia, using AB's definition of reasonably foreseeable, that's fine. If that's not what reasonably foreseeable means and it means something else, then we need to know that, and that needs to be owned and clarified by the federal government. in that article that I just mentioned from Joan Bryden in the Canadian Press, Minister Lametti said, oh no, it's, reasonably foreseeable means what clinicians have said that it means and what they're currently working with. If that's the case, that's great, but that needs to be clarified. What does a clinician with expertise mean? So if your natural death is not reasonably foreseeable, I think I know what it means. They didn't say specialist, and I'm hoping it means a clinician with experience. But are all clinicians going to be comfortable with saying, well, I've seen 6 patients in the last 10 years with Parkinson's. Do I have expertise? So I think that might come from the clinician community to help us understand. And then what I've just mentioned about if you go from the, where you're your natural death is not reasonably foreseeable to where it is reasonably foreseeable, can you use the advance consent clause that's allowed for Audrey's Amendment? Big question, how does the government justify the complete exclusion of people whose sole underlying medical condition is mental illness? I think it's just a serious breach of people's charter rights and one that has to be answered by this government. And then that last question, are we comfortable that for people whose natural death is not reasonably foreseeable, that 2 clinicians have to agree that serious consideration was made? Feels a little bit paternalistic to me, and I think could be potentially problematic for some people. So what is good potentially? And I'm using potentially because I think that's really important. I know some people have come out and said, oh, the legislation is going to be awesome. Some people have come out and said, no, it's really problematic. It depends, and language and what things mean here are really, really important. So removing reasonably foreseeable as an eligibility criteria, provided that it means that the person's death is either in close proximity or that they are on the predictable trajectory towards death, a la AB decision, then that is great news, if that's what it means. Certainly only having one independent witness and opening up who can be an independent witness, that is excellent news for access. On the reasonably foreseeable side, removing the 10-day waiting period, that is very good. And then of course, having Audrey's Amendment to be able to waive the late stage consent requirement is also very good. As we look at some problems, as I've mentioned again, that they're still using reasonably foreseeable now as not as an eligibility criteria, but to determine which safeguard track you're on. The whole idea of having one clinician that has expertise in the cases where people's natural death is not reasonably foreseeable, and then not being able to have Audrey's Amendment available if you're in the non-natural death is not reasonably foreseeable track. And you can imagine that there might be people who have very serious chronic conditions where, maybe they could potentially live for 20 or 30 years. But some of those medical conditions that they have or their medical condition might, result in them being very precarious overall in their health. Could they potentially be at higher risk for stroke or slipping into a coma or losing capacity because of the types of pain meds they're taking? So that is an issue. And I think it's an important one for us to ask. It's great that we have Audrey's Amendment for certain people. Why don't we have it for other people whose natural death is not reasonably foreseeable? That's an important question. And I think there's a real major question with, just trying to pull up, the idea that people have to wait 90 days and face more intolerable suffering. I see you, Martin, I'm just wrapping up now. And then the full-on exclusion of people whose sole underlying condition is mental illness. And I'm just gonna leave with this one last slide before we open it up for questions about things that I think that you, when you're writing to your MPs, that organizations who are working on these issues really want to ask for. One is the immediate clarification on what reasonably foreseeable means. That is so important because it determines how good C7 is or not. That clinical expertise actually means experience with other patients. That Audrey's Amendment, in my opinion, and I just speak as a free agent here, should be considered for both safeguard tracks, and that This last one here, I've discovered apparently it's very difficult to bind future governments to promises of including certain types of legislation. But I think it's a really important consideration given the political climate that we're in. The Liberal government is a minority government, and it's quite possible in the next year or two or sooner that their government could fall and another government could become the government of Canada if an election is triggered. And so what I would like to see, and I'm sure that there will be law professors weighing in on this, is that there is a sunset provision on the exclusion for mental illness, advance requests for people who have things like dementia, and mature minors. I suggest December 31st, 2021, because if we don't do that, these reviews are going to happen over the summer. There's been a lot of money that's poured into this by the federal government looking at these three areas. And if there's no way of ensuring that people are going to, who are in these exclusionary categories, accessing assisted dying in the future, then I question why we went through these exercises and have given, the dangling of hope in front of people. So I think that we, either include the mental illness as a sole underlying condition now, and or add it as a sunset provision that those exclusions will be up as of December 31st, 2021, and people will be able to access an assisted death. And I'll leave it there. I know that was a lot of information. I hope it's helpful, but I think if you have a lot of questions and if you are confused, it's because right now there is some confusion, and I think that's totally fair. I'll turn it over to you, Martin.
Gremlins. I think we have gremlins on our slides, so sorry about that. But I appreciate the calls to action. Shanaaz, you have really presented a lot of very helpful information. And I think in some ways, I'm still more confused now after the presentation than I was before with some of the issues that you've raised. So one of the questions that that's been asked, and I know as we have an aging population, like this is increasingly an issue, is where does dementia or of its various kinds, Alzheimer's, PICS, multi-infarct, fall in all of this? A person diagnosed and well into dementia may be deemed incompetent and not able to make decisions on their own health.
So I'm going to answer that in two parts. One is if you have a diagnosis with dementia today and you still have capacity, depending on how the symptoms have articulated, every person is unique with these sorts of conditions. You may be eligible for an assisted death now. There have been 3 cases that have been reported, one in the Globe and Mail in the fall, another one in CBC in the fall, and then most recently one in the Guardian a couple of weeks ago. Those cases rely on the AB decision, so their natural death is reasonably foreseeable. They also build the body of evidence, as Audrey Parker's case of people who've been assessed and approved, of people who might still be choosing to die too early. And that's certainly the case of the Canadian woman, I can't think of her last name, apologies, in the Guardian. You can Google it and look it up, that she decided that she was going to have an assisted death while she could. She had dementia. She would have liked to live a little bit longer, but she was worried that she would lose capacity and lose the right altogether. So it is possible to have an assisted death now, and would be in Bill C7 if reasonably foreseeable means what it does from the AB decision. But for people who want to make an advance request for some time in the future, even if they have the diagnosis now, these conditions can move quickly in some people, very aggressively, and slowly in others. And they want to be able to make an advance request. This legislation at this point doesn't include it, and there's no guarantee that even after these reviews are done, once they start in the summer of 2020, that they are ever going to be included, which is why I think sunsetting the exclusion is very important because it's a way, possibly a way of ensuring that a future government, if it's not the Liberal government, will include it. And in my experience, when I was at Dying with Dignity Canada, the issue of dementia is the #1 issue for most people when they think about assisted dying. There have been multiple surveys. Dying with Dignity did another one this year and found, I think it was 85% of people want to be able to have the option for an advance request should they have dementia. And the numbers are quite high. Even if it's not dementia, it's the what if scenario. What if something catastrophic happens? What if I have, a catastrophic stroke? People still want to be able to make an advance request in those cases as well, because we can't necessarily predict. So it's an important question, and I think that, the government is only opening up the criminal code because of the Gladue and Truchon case. They went a little further to include Audrey's Amendment for people who've been assessed and approved. I think we should push them further for a commitment to make sure that advance requests will be included in the future.
Okay. Yes, another comment. Yes, confusing. So if a specialist who knows the patient and the condition is very religious and against MAID, they could refuse to give an opinion on the patient on religious grounds, I suppose.
I would say no. That if you have, keep in mind that the legislation doesn't say that you need to see a specialist. You need to see someone to assess you who has an expertise in those particular conditions. And I think the government was very intentional in using expertise as opposed to specialist. And I think that provision is largely to satisfy some groups of people who might be opposed to assisted dying, that there's some extra level. But I think there will be a number of clinicians who will be very comfortable. I've seen, 20 people with Parkinson's in the last 10 years. I've got some experience in this. I have some expertise in it. I think where we can look to get some sense of consistency is, I think we should look to the Canadian Association of MAID Assessors and Providers, CAMAP, to provide those guidelines so that it's consistent across the country. I don't know that the government is the right people to define it. I think it would be helpful, but I think we need to look to the clinician community to define what expertise with a medical condition for someone whose natural death is not reasonably foreseeable. And I think there's a larger question of just taking out the second safeguard track altogether. But getting to the second part of that question around denying people access. You probably don't want to get an assessment from someone who is opposed to medical assistance in dying. I don't recommend that, but whatever notes that they have to take, charting their history with you and the progression of your illness, those have to be turned over. And that currently happens now, where clinicians are assessing people who, they're not their family patient, but they've been referred to them, and they can have access to the person's medical records. And the last thing about that is clinicians who have a moral or conscious objection to assisted dying don't have to assess, they don't have to provide, and as I've mentioned, I don't think you want them to do either of those things, but they do have an obligation to provide you with an effective referral to another clinician who can assess and provide if that's the case. So it's a question with lots of different components loaded into it.
Right. One of the questions that I've been mulling is in terms of accessibility. So we have data, let's say there's 13,000 people who have had a MAID death. Is there data on accessibility? So for example, I think if we're in urban centers, it's much easier to have a MAID death, to have it an independent witness. What about rural, remote areas in the country?
Yeah, I think that, so Health Canada has set up a reporting regime. We haven't seen that slide that's from the Government of Canada that I included in the presentation, was part of their slide deck when they were introducing the draft legislation for C7. But there is extensive data collection going on. We haven't seen the results of it yet. I think by the end of this year, if not sooner, we will see that. That was instituted in late 2018. And so there will be data in terms of location. There's also going to be data around, sorry, accepting patients who have been referred, around forced transfers for medical assistance in dying. There is going to be some data to help us understand some of the issues. I do think that, you know, when we look at healthcare sort of writ large, and we recognize that we already know a lot of the access pain, you know, points in the system for people who are trying to access healthcare, whether it's rural, remote, urban, language barriers, people who have difficulty communicating and have to find other ways to communicate, immigrant communities. When you add assisted dying onto, you know, into and integrated into a healthcare system, all of those same problems, they're still there, right? And in fact, if anything, they will feel more acute because of where that person is in their healthcare journey and where they are in their journey of life of trying to access an assisted death. So it's definitely going to feel more acute, and we will see a little bit more data. But I think if we look to other data points, looking at healthcare in general and where there are pain points around accessibility, we're going to see the exact same thing for medical assistance in dying.
Okay. And finally, in Oregon, one of the, and as part of their implementation of assistance in dying through the Department of Human Services, they have comprehensive statistics that they publish every year. And they're all, you know, they're collected in one place. So it makes it super simple, capturing things like the diagnosis, the demographics, the age, etc. Do we have any similar reporting system in Canada where this comprehensive data is combined?
It's a really good question, because one of the things that the Oregon data has been so helpful in determining when they first you know, introduced assisted dying in that state. And, you know, before that happened, there were a lot of, we're going to call them, you know, fear mongers, you know, people who were making all sorts of charges who were opposed to assisted dying, that it was going to be people who are Black, from poor socioeconomic backgrounds, without education, post-secondary education, that would be suddenly lined up to have an assisted death. The Oregon data is so helpful because that is exactly the opposite of the truth. That, you know, most of the people in Oregon who are having an assisted death are white, they are middle class or above, and they have more than post-secondary education. And, you know, in Canada, we collect some data, but a lot of the diversity data that's collected in the US in a number of different areas, it's not collected in Canada. So what we're going to see in Canada is we're going to see age, we're going to see you know, gender, we're going to see diagnosis, we're going to know you know, what communities, what provinces, you know, the rural, remote, we're going to know that, but we're not going to have data around issues around language. We might have some data that's suggested from the medical conditions that will be reported on significant disabilities. I could see that data easily coming from that. But we're not going to know other demographic data that we have in the US. We're not going to have that in Canada. That diversity data is not going to be available. And I think that that's problematic, that it won't tell us enough about who's accessing and then who's not accessing and why they're not accessing. So I think that that's something that I expect will take a number of years before it's addressed.
Right. Which is really unfortunate because we still have the naysayers and the slippery slope folks and who are going to be there. And if we're going to, we see them in other parties in government as well. And so it's an issue that, you know, unless we have some of that data to be able to present,
Well,
it's problematic.
I will say that there was a recent study that was published in the Canadian Medical CMAJ, the journal, I can't think of what exactly the acronym, how it exactly spells out, that was conducted looking at some of this data. It wasn't national, but it was, I think a significant enough sample size to be able to draw. And it sort of confirmed that, yes, these are people with, middle class, with education, that worry, it doesn't exist in Canada, it doesn't exist in the US, it doesn't exist in Canada. My concerns are actually for people who may not have access, who may not have a family doctor. And there are certainly people in this country, I know of cases, people who've been homeless, who've been able to access assisted death. We know of cases of people with different, ethnic backgrounds, different language issues, but it's all anecdotal. And I think that study was really important, and it was led by Dr. James Downer and I believe Professor Jennifer Gibson, looking at that for precisely those reasons, Martin, to sort of, the data demonstrates that, the vulnerable people who are accessing MAID are accessing MAID because they're eligible for MAID, not because they're in certain communities that are targeted. And I think that's important, but I do agree with you that having that on a national level would be one more way to reassure the public. The other thing I would say is trust in the clinicians, the doctors and nurse practitioners who do this work. I think most of them are very thoughtful, they're very compassionate, and they recognize that, yeah, of course we want people to live as long as possible, their best lives as possible, until that's not possible and they can't live that way. And I think and I know a lot of the clinicians that are involved in assisted dying, and I put my trust in them. And yes, it would be great to see that data in the future, but in the short term, we can really look at the Canadian Association of MAID Assessors and Providers to give us that guidance, to give us that trust, and to really build the confidence in the clinician community, including making sure that the clinicians stay, within the law. So I think we have a number of pillars to help support us through, and that the people who fundamentally oppose assisted dying, they're always going to fundamentally oppose assisted dying, regardless of what the evidence is. This is something we've seen play out, right? So I think, those are my thoughts. I feel very optimistic that there are so many good people that are working on this file, and the public is driving, what they want in assisted dying, and human rights should always belong to the public. So I feel pretty confident in where things are, but it also means that we still have to stay vigilant. And we have to press the governments to clarify and do better, and to be inclusive with their legislation, to ensure that CAMAP is providing guidance to clinicians across the country, so that the rest of us, the lay people that we are just trying to navigate through life, understands what this means, how it works, and how it will work for us or a family member and a loved one.
Yes. Well, Shanaaz, your passion, your energy, your focus really comes through. And so I really want to thank you on behalf of all of us on the webinar and Humanist Canada for bringing your wealth of experience and insight on this incredibly important topic. I know you've made a huge difference in the landscape of MAID in Canada, and I think it's really important to acknowledge that. So thank you. So imagine a big round of applause right now. So as we draw to a close, I also wanted to acknowledge that, and Shanaaz, you're welcome to join us on April the 5th is going to be our next webinar, and our presenter will be Dr. Christopher DiCarlo, and he's actually going to be talking about critical thinking in a post-truth world. And so we invite everybody to come out next month on April the 5th. So today, really on behalf of our webinar team, myself, Anna Popovich, who's been following with questions and on the technical side, and of course our presenter, Shanaaz, we thank you for joining us. So until next time, we wish you all very good health in these strange times. And as Shanaaz mentioned earlier, we've all done our bit through this webinar to practice social distancing. So may you all enjoy the rest of your day, and we'll look forward to having you back on Sunday, April the 5th at 3 p.m. Thank you again, Shanaaz.
You're welcome. Thank you.